Yes, welcome everyone. Just I want to introduce Susan. She's she works as a clinical risk advisor with Ireland CLG. She is passionate with dedicated to improve the quality and safety of patient care. She's also an expert in the risk management education and has developed and delivered risk management education and training to healthcare professionals. And to embedding the principles of human factor science in order to improve the quality and safety of patient care. We are so happy that we are having you with us today, Susan, and to speak about the managing the challenges which we face in patient care and as a family physician. We are so happy to hear this from you. Welcome.
Thank you very much, Isha, and I'm delighted to be here on behalf of ICGP to present to you all today on managing challenging interactions with patients. So just to give you a brief introduction, my name is Suzzane Creed. I'm a clinical risk consultant. My background is a clinician, and I've worked in Irish general practice for almost 15 years, and I've really enjoyed working in the primary care setting, and I think it's a real advantageous place to be because you really get to know your patients so well, and sometimes depending how long you're in the job, you're looking after generations of family, and I have been very privileged to work in the area I live in, so to get a real I suppose close relationship with many patients, and you see generations from birth to death and everything in between. General practice is no doubt a challenging career at times, and I suppose you've all, like ourselves on this side of the world, have been through the COVID pandemic and still experiencing the challenges that brings. So hoping you have all survived and haven't lost any loved ones. Today's talk is on managing, as I said, challenging interactions with patients. And I suppose if you think about even just outside the area of primary care and medicine, there's conflict in every walk of life, be it when you go to the supermarket or any interactions, even on a personal capacity. And usually, challenging interactions usually start with something very, very minor, and then they may escalate to something more serious. Unfortunately, that can be sometimes aggressive behavior or even a violent event or an attack. And all staff working in healthcare, including primary care, have a right to work in an environment that's free from harassment, free from threat. Nobody should have to put up with the threat of verbal or physical abuse or harassment or violence. And hopefully by this practical, I would say it's a real practical workshop, you will have some practical tips to take back to your everyday clinic and share with your colleagues in the clinic and in the healthcare setting. So just an outline of today's, I suppose, timelines and events. The talk itself will be about 45 minutes, and we leave plenty of time afterwards for questions and answers. And thanks to Isha for chairing the session, and Brian for looking after the IT in the background, a real essential skill. So I thought I'd give you a little bit of geographical history as to where I'm from. I'm based here in Cork. It's the south of Ireland. If you can see the map on the right, the little red part is Cork. And Cork, for any of you that haven't been here, it's actually the largest county in Ireland. Our colleagues, the likes of Brian and Dublin, often think, even though it's the capital, Cork is the biggest county. I had to get that in there, Brian, I'm sorry. So, and in the photograph here is Blarney Castle, and Blarney Castle is about 5 kilometers from where I live right now. And Blarney Castle is very famous for a stone that's at the top of it. And there's a little old fable or historical story going with the castle that if you were to kiss the stone at the top, you get the gift of what's known as the gab or the chat. You're good at talking. So being reared beside it, I suppose I did get that gift of chatting. But also we're renowned in Cork for speaking very fast. So I'm going to make a real conscious effort at this workshop to speak a little bit slowly. If I'm talking too fast at all, please interrupt me and tell me to slow down. So moving swiftly onwards, this is an overview of today's or tonight's session. We're going to look at why a session on challenging interactions, why it's important in healthcare. What are the trigger factors? What causes an interaction with a patient to be challenging? Are there trigger factors or underlying risks that trigger that that challenging interaction. Then we're going to look at the importance of good communication. I'm going to give you some practical tips on how to manage a challenging interaction and some practical tips to reduce your risk in your healthcare setting. And if you think about it, interactions between patients and medical practitioners can, of course, sometimes be challenging. Hopefully not all of your interactions, and that some are only challenging. And we've all had consultations where the interaction was suboptimal, either as the clinician, the doctor, or the nurse, but also perhaps you've experienced it yourself as the patient. If you've gone to see a clinician, perhaps the outcome or the consultation itself didn't go so well. And neither party, neither the patient or the doctor, normally wishes to cause a difficult situation, but common misunderstandings by both parties can often result in the challenging interaction occurring. And I'd like to highlight, I suppose, at the start, and I'll reiterate this throughout this talk, that communication and listening skills are essential, not just for every consultation, but in particular for situations where the interaction has become more difficult or challenging. And I'm going to discuss those two aspects of the consultation in a little more detail later on tonight, because my background and coming from working in the, I suppose, indemnity sectors that I have now been working in over a decade across Ireland, the UK, and I'm now with a company that have partnership with the largest indemnity organisation in the States. And we see a lot in our claims, complaints and litigation that actually communication and listening are not necessarily make the whole case, but actually can be a contributory factor to a claim or a litigious case. So they're really, really two important parts, and I suppose two aspects of the consultation that I'm going to be harping on about a little throughout tonight's talk. So hopefully at the end of the session, as delegates, you'll have a better understanding of the common trigger factors to challenging interactions. You'll understand the importance of good communication and listening skills when dealing with patients, and you'll be able to develop strategies to manage those interactions that escalate into a violent or aggressive behaviour or incident at the healthcare centre. And this, as I said, already, this will hopefully reduce the risk of complaints or claims arising from those difficult interactions, because often they start as small and can just escalate out of proportion, and possibly maybe a subsequent claim for something that has started off really small and the patient has decided, I didn't like this, perhaps I'm going to take a case or write a complaint to the clinic. So I would like, as far as possible, as I said again, for this this workshop to be interactive, and I'll have some questions for you, and please feel free to either drop your answers in the chat box. So I thought I'd start off with a scenario. So imagine you've had a very busy day at work today, and perhaps maybe the computer system didn't go so well, so that was challenging. And then you were running late, and maybe extra patients added to your appointment list. It happens all over the world. I've no doubt it happens in Saudi Arabia too. And your next patient comes in, and let's call her Fatima. She's a 34-year-old, and she attends with her very young daughter. Mum says the child has a fever and a cough, and she's requesting an antibiotic. So as the clinician, you examine the patient and you feel the child has a viral illness, and you suggest treatment with antibiotics to mum. But mum becomes annoyed, and she's insistent that she wants you to prescribe antibiotics, and really that's the bottom line, she wants antibiotics. So you have a difference of opinion, an argument ensues, and mum leaves the consultation really upset and annoyed. Now, how would this make you feel? Anybody want to think what emotions they'd feel? You've had a busy day. How does it make you feel having had a challenging interaction or a challenging consultation? Oh, I see a lovely note in the chat box that somebody misses Cork. Anybody want to pop in? How would you feel if you have had a really challenging interaction with a patient? Okay,
Hello.
frustrated. You'd be frustrated and slightly agitated, yes, can leave you upset, can't it? And especially because all of us come to work to do a really good job. None of us come to work to upset the patient. You might feel incompetent. That's unfortunate, because in most scenarios, you're trying to do a really good job, but obviously difference of opinions happen, and it leaves you feeling really, really challenged. Exactly, Atef. I agree with that. So there's lots of research out there actually as to feelings and emotions surrounding challenging interactions. And a challenging patient interaction can result, as I said, and some of you put this up already, clinicians feeling frustrated, helpless, fear and resentment. That's Elder et al. In 2006. Common emotions that were experienced by clinicians following a challenging interaction. And often the challenging interaction may result in your dislike of the patient. You kind of have your ideas now going forward. I don't think I like this patient really much. It might compromise your ability to provide good care because you're feeling challenged. It can perhaps increase the risk of error, and subsequently maybe the patient being dissatisfied with the service they receive and they're looking for a second opinion, or perhaps a further consultations with another clinician at the clinic. And these are all the consequences that can happen. And despite you wanting to do a good job, at the end of the day, it can really throw you off kilter or throw you off, you know, your train of thought and make you feel quite upset. And unfortunately, even after a difficult, challenging interaction, that patient goes out the door and you have to put on the smile for the next patient coming in. And that can be really, really difficult and really challenging to do. There's research published in 2015 by Schmidt et al. And they looked at what were the consequences of challenging interactions when dealing with patients. And actually, clinicians are 42% more likely to wrongly diagnose a complex issue and 6% more likely to wrongly diagnose a simple medical issue. So actually, challenging interactions, as well as having implications for the doctor, also have implications on the care provided and can lead to, you know, an adverse incident or a wrong diagnosis. So it affects both the clinician and the patient. So that really, I hope, has highlighted to you the reason why you need to have a workshop on challenging patient interactions. Unfortunately, they happen all of the time, but it's about putting the systems in place to reduce your risk. So the next part of the workshop, we're now going to look at what are the trigger factors. And again, research by Adams et al., and albeit back in 1998, the subsequent research, a lot of the articles written would come up with the same components. They say there are three actual components of a challenging interaction with a patient. There can be situational issues, that's like the clinic or the environment or the healthcare system. There can be particular patient characteristics, which actually lead to the difficult interaction with the doctor, but also us as clinicians, we can have particular characteristics or issues that can also complicate or cause the challenging interaction in the first place. So what I'd like you now to think about, what actually are the patient triggers? What are the types of patients? What are the issues perhaps that could cause a difficult patient interaction? What are the types of patients that might cause a difficult interaction within your clinic? And again, feel free to drop your answers in the chat box. So demanding patients, very good. Anybody else like to think of what could be a particular patient type or a particular trigger factor? Angry, demanding patients, they're the same all over the world. We have them here too. You feeling challenged? Yeah. Okay, so let's look at the list I had here. So somatization patients, very good. Shopping patients, so very good. We call them frequent flyers on this side of the world. Those patients that, you know, frequent attenders. Addictive patients, patients with a different agenda, very good. Patients with a bad previous experience, yes. Unresolved issues or unresolved complaints, they can also lead to a challenging interaction. Patients with a personality clash, and I always like to highlight that in any walk of life, and because there's so many different personality types, You're not always going to get on with all of the patients all of the time. There will be the very odd patient that you might have that personality clash and you have to work a little bit harder. But it's really important to point out, and I think this is really important at the beginning of this workshop, that it's okay to have the odd personality clash. But if you're finding all of the patients difficult all of the time, the issue is more likely to be with you, and perhaps you're burnt out or overworked or fatigued, and you need to take a step back and look at yourself. And can there be issues that you can you get help to help with? Because if you're finding all the patients difficult all the time, the issue is more likely to be with the doctor rather than the patient. So personality clashes can happen on both sides of the fence. Communication issues, perhaps if you're not, in our scenario here, if English isn't your first language, in your scenario, if it's not, if you and the patient haven't the same language, or if there's language barriers, perhaps patients with mental health issues or addictive patients or drug or alcohol abuse might be an issue. I think particularly what we've noticed here during the pandemic is challenges with patients that have actually lost their job or have financial issues due to COVID can often result in a challenging interaction, or the patient being more anxious at the consultation. Time pressure, I'm sure you've all experienced that. The patient that comes in and through no fault of your own, you're running late. The patient outside in the waiting room doesn't realise all the patients you've seen that day and the particular challenging consultations you may have. And the patient might be under time pressure. And when they come in, they're already looking at their watch or the clock. So, the consultation is starting on the wrong foot already. That can have an impact, obviously, on the consultation. And I always remember, when you go out to call the next patient in the waiting room and you see your patient and they're probably pointing to the watch on their hand or looking up at the clock, you kind of know there's a bit of a challenging consultation coming on board, and you might have to address it at the first instant when the patient comes into your room. And again, other issues with COVID, I suppose we have certainly noticed it here with elderly patients, is that loneliness and isolation through the COVID pandemic has also been a challenge for some patients, and that can lead to a challenging or a difficult interaction in the consultation. Again, there are other issues that can happen with the patient themselves, or perhaps the actual disease that they're suffering from. All patients, from time to time, including ourselves, they can have unrealistic expectations of what they're going to expect at the practice. Perhaps they're over expecting of a service that can't meet their needs. They might be unwilling to take responsibility for their own health. They expect the doctor to have the instant fix. Patients may have another or an alternative view to the treatment. Perhaps they don't agree with the medication you're prescribing. They might want to go down the herbal route or the alternative therapy route. You'd have obviously the uncooperative or disruptive patients. Patients with chronic pain, obviously pain can wear a patient down, and it can be challenging. The issue mightn't be easily fixed. You have those patients who, coming, as you said already, the frequent flyers or the frequent shoppers can't get to the bottom of their diagnosis, and it's a bit more challenging. You see them coming again and you really don't know what's going on, or you can't get to the base of the issue, and that can lead to obviously to a difficult or a challenging interaction. Perhaps a patient with a terminal illness with a little prospect of improvement, that can also have an impact on the consultation. And managing such affected illnesses may feel more challenging than actually dealing with a patient who's the straightforward cough or cold, and that's easy to deal with. So the clinical symptoms obviously play a part here. So they're the trigger factors from the patient's perspective. So what do you think are the trigger factors from the healthcare system, the environment in which you work? And I'd be really interested to hear these, to see, do we share many of the same challenges within the healthcare system as you do in Saudi Arabia? So what are the kind of challenges or the environment or the healthcare system issues that can challenge, or create a difficult interaction for the patient on your side? Feel free to type into a busy clinic, yeah. System shutdown, IT issues, oh gosh, we have them all over, when the computer system crashes and you can't access the previous clinical record. System shutdown, yeah. Busy clinic, overbooked. Administration issues? Fatima, very good. I think we shared lots of commonalities with the healthcare system. Lack of nursing staff. Actually, that's a real problem here in Ireland. We have very few practice nurses in our general practice system, and it really has been a challenge in the pandemic and running vaccination clinics here. Lack of medication and medical records, meds unavailability. Interesting to know, is that due to the pandemic or generally speaking? Poor triage due to lots of patients, long waits to see other specialities. Gosh, the staffing issues, yeah. Okay, we seem to have a lot of the same issues across the globe. Gosh, healthcare systems, delayed referrals, delayed diagnosis, lost referrals. Gosh. Okay, so here are some of the ones. See, have I got them all? What other ones had I on my list here to see are we on the same page? Managing expectations, lack of appointments, lack of access to other services, waiting times, lost prescription, unresolved complaints, lack of privacy. I wonder, have you had that issue on your side? Sometimes perhaps I understand a lot of your healthcare facilities are designed and big, larger practices, but sometimes on this side of the world, if you're in a small practice, even just the design of the practice and patients coming to the reception area of the clinic, you know, the conversations may be overheard in the waiting room, and that can, you know, lead to frustration and a difficult even interaction at reception, not a mind inside with the clinician. And the other thing I've certainly seen throughout this pandemic, and as I said, I work as part of a clinical risk advisory group in a medical indemnity organization, is patients refusing to wear PPE like masks, because masks are mandatory over here. And actually it has been a real challenge for some consultations where the patient refuses to wear the mask or to use the hand sanitizer during the COVID pandemic. And that, before they ever see the doctor in the clinic room, has led to a difficult interaction, because obviously as clinicians you want to protect yourselves and your other colleagues within the clinic. So there are some of the kind of system or environmental factors that can lead to challenging interactions. And then, of course, thinking about ourselves, the clinician, the doctor, or the nurse in the clinic, there can be issues with ourselves that can actually lead to a challenging interaction. And I think the one at the top is one that I say I would have failed with most, you know, a lot of the time in a challenging interaction, is multitasking. And I think it's the one time, you know, when the patient comes in and they're sitting in front of you and you're trying to type as they talk to save time, and the patient may think actually you're not looking at them and you're just looking at the keyboard if you're not a good typer, or perhaps looking at the screen if you're looking at the past history. Often the multitasking can, you know, the patient gets the wrong impression and think actually this doctor isn't even listening to what I say. There are other factors, obviously yourself, your motivation, you might be poorly motivated, you might have, you know, your own experience of managing challenging interactions, be it outside the workplace, might have been poor. Your personal experience or training. And I always think in the healthcare system, and certainly here in Ireland, and I wonder is it the same, Aisha, in your side of the world, does your undergraduate medical training provide training in managing interactions, difficult interactions, or managing conflict in the healthcare system?
Yeah, it is supposed to be in the curriculum of the medical students, especially when they are in the family medicine courses. As communication skills and dealing with difficult patients is part of this in the curriculum. But
right.
Yeah, you know, this is part of the curriculum in the medical schools.
Yeah.
And also in the postgraduate training, it's
right.
part of it.
Because certainly in years past here, it wasn't addressed at undergraduate training, but certainly now it's great to see it, because when you think about it, it's one of the most important aspects of the interaction with the patient is the communication and the interaction. And obviously when all consultations won't go well, you need to be able to manage the difficult scenario as well. So training is so important. The other thing that can happen, and even if you work in a busy clinic where there's multiple clinicians, doctors and nurses working, is the clinician that's lone working. Perhaps you're running late in the evening and your colleagues have gone home. And if you've had a challenging interaction and you're on your own in the clinic because maybe the others have left or it's late in the evening, that can be quite difficult as a clinician. Poor communication, and you know, as the doctor or the nurse in the clinic, your own skills of communication may be poor. You might be unwell yourself, perhaps, you know, an underlying illness, and you're coming to work because you don't want to leave your colleagues down, and the clinic is busy, and you know if you stay at home that your colleagues are going to be overburdened or overpressured, and they all can lead to a challenging interaction from the clinician. Because think of it, we're human ourselves. We also can be patients from time to time, and you know, we may not be on top form every day, and just being aware of your own, I suppose, background and your own issues that may be going on in your own personal life that before you ever come to work may complicate or worsen the situation, because you know you might be on top form yourself. So being aware of your own behaviors that could adversely affect an already conflict or an already challenging interaction with a patient, because ourselves, we're only human too. So there's some of the trigger factors for the clinician or the healthcare professional, but also think about, and I'm sure this happens, you describe very, very busy healthcare systems in your country too, is actually, do you look after yourselves? You know, when you're running late, are you hungry? Are you angry? Are you late? Are you tired? Have you heard of HALT? So looking after yourself, you know, keeping yourself well hydrated, nourished, taking your breaks are also important to being able to function correctly, and that may help in a challenging interaction. Again, I said personal factors. If you've something else going on in your own personal life, perhaps an elderly parent or a sick child at home, sometimes that affects us on how we perform in the workplace or how we interact with others. You know, if you've something else bothering you going on in your life. How about disruptions in consultations? Do you get disruptions, Aishia, in your clinical setting? Do your admin staff interrupt you mid-consultation?
Yeah, it could happen during the consultation or in the practice.
Right. So like taking phone calls maybe from somebody in secondary care or the local pharmacist?
Yeah, this is commonly happening in the practice, or a nurse is coming to ask about something for another patient, or a physician, another door is coming to ask you about something. This could happen in the practice.
This can happen in the practice. And if you think about it, if you're the patient at the other end of the desk and you see alas, as there, it happens very frequently, and so do you, Majed. If you think about it, if you're the patient at the other end of the desk or the consultation and you see your clinician being interrupted, you think, oh my gosh, is the doctor more concerned about the person coming in interrupting me? That can actually lead to a challenging interaction, can't it? Because you feel undervalued and you feel, I'm here, I want my time with the doctor. So that can actually you know, also cause a challenging interaction or a challenging consultation. As again, I said, personality types, you know, doctors can have personality issues as well and have personality clash with the patient. And also, I think we tend to, you know, human nature, we stereotype patients too, don't we? We all have those patients on our list, the heart sink, you know, the frequent flyer or the frequent shopper. And when you come in the morning and you see them already on your list to be seen today, it, you know, it puts the little knot in your stomach, you know, oh no, they're not here again. So we do, you know, human nature is we do stereotype patients, and, you know, you mightn't like all the patients, and it can, you know, I suppose your innate personality might show that you dislike a patient, or it might, you know, it might make that in a normal interaction more challenging if you have, I suppose, an inbuilt stereotype of the, you know, stereotype the particular patient. So that can also lead to a challenging interaction. Okay, so moving on to the next part of the presentation is we're going to really look at, again, I said, at the importance of good communication. And as I said, it's really, communication is so essential and important in any interaction and in any consultation. Good communication, but also good listening skills, but particularly when it's a challenging interaction or a difficult interaction with a patient, you really got to focus and zone in on the communication and put in the extra effort. So just to describe a little bit of research done many years ago by an American psychologist known as Albert Mehrabian. He's very well published and very well known for his work on communication and his research on communication. And even though it was done back in the 70s, it's still very relevant today. And he looked at, in any given communication, what is actually liked about the communication or the spoken language that's said. And actually only 7% is weighted on the spoken word, 38% is weighted on the tone of voice, and 55% is on the body language. So it's not always about what you are going to say, but actually how you're going to say it. You know, you might remember the saying, a picture can paint 1,000 words. So actually how you're saying something is equally, if not more important than actually what you're going to say. So if you think about tone of voice, and let's say perhaps as I look into the camera right now, but perhaps if I came in this evening and I was looking out my window here and I was speaking in a real dull tone of voice and not engaging or looking at you, or perhaps, you know, raising my eyebrows, you'd have got a very poor impression and you'd have probably thought Suzzane is going to be really dull and boring tonight. But I hope that by smiling and engaging and giving a friendly tone, I gave you a very different impression. And so your tone of voice and your body language can play a real important part in a consultation, and particularly if it is a challenging interaction. So thinking for a moment, what do you think? And again, you can pop these in the chat box. What are, you know, what types of body language display poor body language, or what are poor signs of communication in a body language? Anybody like to pop them in the chat box? Or good signs of body language? Cross hands, yeah, so it's a kind of a closed, you're not engaging with the patient, fantastic. No eye contact, yeah, slouching, eye contact, exactly. No eye contact, looking at my watch, yeah. You're probably thinking, will they ever get out off the chair and go out to the next patient? Look at my watch or my phone, yeah, very good. Looking at the computer, and I think that's a real important one, because sometimes, you know, if the patient feels, Brian, that you're not, even though you're probably listening to what they're saying, but because you're concentrating time, it can often lead to a challenging interaction, because the patient perceives that actually you're looking at the computer and not listening to what they're saying. Too much writing, yes, that can often get you in trouble. So some looking to the file. And sometimes if you explain to the patient, look, while you talk, you know, I'm going to type your condition into the computer, that can be okay. But if it's a challenging interaction, sometimes you've got to just focus particularly on what's being said. Pointing the finger, how about sighing, or, you know, pointing the finger? How about if I'm banging the book around the place? They are all signs of poor non-verbal communication. So just moving on to the next slide, I've obviously listed a few of them here. So raising eyebrows, you know, you're showing disinterest, or would they ever stop? Twittering on, maybe you're thinking. Eye rolling. Sighing, as you said. Nodding can be a good sign of communication. You know, as you're talking, I'm nodding, so I'm showing I'm listening, or even just, you know, saying something like Yawning or stretching looks like you're tired and you want to go home. Open palms can be a sign of, you know, good communication. And again, as we've said, banging furniture and pointing the finger can be signs of aggression, or, you know, kind of you're dictating to the patient rather than you're talking at them rather than talking with them. So being aware of your non-verbal communication is really, really important. Now, as well as communication, listening skills are a key aspect of any communication interaction, and a key aspect of good communication is also having good listening skills and listening attentively to what the patient says. And I think this picture says it all, really. Is actually, you know, I remember when my children went to school first, the eldest boy was told by the teacher that the reason he's got 2 ears and 1 mouth is that he had to listen twice as often as he spoke. Now, I think from the teacher's viewpoint, that was to keep the class of 40 children quiet, but it actually is a real good analogy. It's actually, you also need to listen well as speaking. And active listening is the process by which an individual secures information from another individual or from a group, and it involves paying attention to the conversation, not interrupting, and taking time to understand what actually the patient is saying, what they're discussing. The active element involves taking the steps to draw out the detail, and sometimes you might just have to ask 1 or 2 questions to get the full information that otherwise mightn't be shared. And active listening is really helpful, because otherwise We might just get from the conversation what we want to hear or what we think we hear, what you think you hear, but by active listening, you actually pick up the facts, and you can get more out of the conversation by actual active listening. And there's three different parts to active listening, and they are the attention, the hearing, and the responding. And I've kind of covered these already, but the attention is focusing your attention on the patient. And this is particularly important in a challenging interaction, that you make good eye contact, as I now focus on looking into the screen. You know, nodding can show that I'm listening attentively to what you're saying. You're hearing, you're listening to what is being said to you, both the content, but also the emotion behind the content. So if somebody is annoyed or upset, you can actually acknowledge that. Remember, it's really important not to interrupt the patient. Let them finish their sentence, because actually the patient is much more likely to listen to you if they felt they've been listened to in the first place. Sometimes you need to ask questions to gain clarity, or maybe perhaps to gain further information. Oh, I love this, Alea. The active listening, the golden 1 minute at the beginning of the encounter. That's really nice, where you take it all in. That's fantastic. Thanks for sharing that. Responding, again, it's about being able to respond appropriately. And sometimes if the patient is annoyed or angry, you might need to take just a second to think about what you're going to say. And it's really important to acknowledge the emotion. And I always think from a medical indemnity side of things, people often say to me, if I say to the patient, I'm sorry you're annoyed, does that mean I'm accepting responsibility? Oh, no, it doesn't. It actually means just you're acknowledging that the patient is annoyed. You're not necessarily saying it's your fault they're annoyed. So acknowledging the emotion is really, really important. If you were upset with me right now and I'd say, dear Alicia, I'm really sorry you're upset. I'm not saying that it's my fault you're upset, but I'm actually just acknowledging it. So acknowledging the emotion behind a conversation or an interaction is really, really important. It also shows the patient at the other end that you're listening and you're taking in what they say. Reflecting back to the speaker what they're hearing. So often just synopsizing what they've said means actually she's been listening to me. She's actually taken in what I've said. And using the patient's first name can also show that you have an interest and that you understand and you know who you're dealing with. So they're just some of the important concepts of active listening and listening to your patients. Any questions so far? Or shall I keep going?
I think people can unmute if they want to ask a question.
Okay. Okay, so I'll just move to the next section, and please do feel free to interrupt me, as I said. So I suppose the next part, I've told you all the triggers, and we've discussed what can make an interaction more challenging, and we've discussed the importance. So now we're going to look at actually, how do you manage the challenging interaction? What am I going to do? The patient is in front of me, thinking back to Fatima. She wants the child to have the antibiotic, and you feel it's only a viral infection. How do you manage this challenging interaction? You want to get it right before the patient leaves, or you want to at least try to diffuse the situation. So some key steps to managing or handling a challenging interaction are as follows. First and foremost, the aim, and I always say, if you think of your personal life, if you have a falling out or a minor dispute, the thing you want to do really, of course, is to set it right and to reach some form of an agreeable, mutual, agreeable solution. You want to diffuse it and you want, if possible, set it right. I will admit at the outset, not all challenging interactions that you're going to find a solution, but at least having a shared understanding of the other person's viewpoint is really important, and aiming to work to a solution is what's key. And to do that, you obviously, in the first step, you need to identify or acknowledge that there is actually a problem. So actually pointing it out that here we are, we have a difference of opinion, you and I are not agreeing, and that can be the patient and you. We need to put it right. So actually verbalizing it and saying it can be the first step in the right direction. See that, Dua? Apologies.
Totally muted that. Keep going there, sorry.
Right, okay, so sorry, I thought they were talking to me.
No, I think it just unmuted.
You muted that.
Somebody unmuted. I hope it wasn't a difficult interaction.
I don't think so.
They can get all the advice. Okay, so the next step then, as I said to you, actually just naming the problem. Say, look, we have a problem here, or we're not agreeing, and I'll give you, a practical tip on how to address that in a second. So verbalizing, identifying there's a situation is the first step to trying to find a solution or trying to de-escalate the situation. And I think it's important, again, be aware of your own response. What triggers or what presses your buttons when you have a challenging interaction? Do you begin to grimace? Do you begin to kind of tighten up? Do you fly off the handle, or have you a rapid, immediate response that actually might make the situation worse? So being conscious of your own reactions in a challenging situation and how you want to respond is really, really important. And also thinking about the patient's behavior. Consider, this is your patient sitting in front of you. Is this normal for them? Is there an alternative explanation for the patient presenting like this? Maybe this isn't their normal type, and there might be something underlying that actually is causing the patient to react like this. It might be, there might be a possible reason. Even if you think you're a patient, you might have a patient in front of you and they've got a family relative who's really unwell, or somebody with a terminal illness, and perhaps that's the underlying reason why they're actually responding. This isn't their normal reaction, and sometimes trying to explore what is the reason behind this can also help to put the situation right. Again, explore possible reasons, and that might be just by reframing or questioning the patient as to the reason they're reacting like this, and that can often help at the very outset to diffuse or stop the situation escalating further. And again, where necessary, perhaps provide the necessary support to the patient, and sometimes it might be setting boundaries. If it's the patient that's coming frequently for their prescription sooner than it's due, it might be just setting the boundaries and letting them know what the system is like so they understand, and you're kind of managing their expectations and they haven't got unmet expectations. So setting boundaries and letting them know how systems are run can often help to reduce a situation from escalating out of control. And when I say about verbalizing the difficulty, it's a bit like, I say, pointing out the elephant in the room. And if you give the example, let's say the patient is Layla. Layla, we both have different views about your symptoms here and how they should be managed. And this is causing some difficulty between us. Do you agree? So you're, putting the picture out there. Here we have a disagreement. So actually, by identifying the elephant in the room, it externalizes the problem from both the patient and the doctor's viewpoint. So you're stating the obvious, basically. And this can actually help create a shared sense of ownership. So it's not apportioning blame or saying you're at fault or I'm at fault. You're saying here we have an issue. And by verbalizing that difficulty, you can actually help to build trust with the patient. And that can really go a long way to setting the consultation on the right foot again. And it opens up the way for considering kind of working towards some form of solution. So actually by saying, look, we're in disagreement here, how can we move forward? Any questions on that? Okay, just moving to the next slide. And I'd like you all, for the next slide, just to pause for a moment. And I'm going to ask you to look at it intently at this photograph. And Brian, you might lodge a poll. So I want you to see, what do you see in this image? Do you see a vase or a vase? Some people pronounce it differently. Do you see two people or do you see it both? And just take one option. Okay, I'll just give you a few seconds. Sometimes it's...
Yeah.
Okay.
I'll give it another few seconds. About half the people have voted.
Yeah. Let me tell you about this photograph. I've been using this for many years at presentations, and I was using it for about 18 months before I could interpret it properly myself. So it's a challenging one. Some people see what you see.
Yeah. So
okay.
I'll end the poll there and see if I can share it. But it's surprising enough, not many people see a vase. Only two people saw.
Oh, really?
Only 2 people saw a vase.
Oh, wow. 6% saw the vase, 43% see the 2 people, and 50% see both. That's interesting, because when I first started using this picture, I could only see the vase. So it's interesting. And I think it's a little bit of fun, isn't it? So it's just, it's a little bit of fun. So just take a moment to look at it. And I think the reason I use this illustration is that actually here we are, 67 delegates at a conference, and we all have a very different view of a picture. And if you take, if you watch any given interaction and you get 2 people to watch it, actually 2 people may come back with very different stories. And, you know, the doctors, if you take it back to your clinical setting and the doctor and the patient relationship, your view of the consultation or the clinic interaction can be very, very different to what the patient views it, or the patients might have a very different view of their illness or their symptoms in comparison to what you as the doctor has. And actually that discordance tends to make us feel uncomfortable. And I'll tell you a funny story. A number of years ago, I went to a practice in the UK, and the practice manager said to me that the doctor was always running late. It was about 20 minutes, but that was normal, and she didn't, you know, take any notice of it. But actually, 20 minutes to the receptionist was nothing, but actually 20 minutes to a patient waiting could look substantially long. So 2 people can have a very different interpretation of the same situation. And the real challenge for you as the clinician or the doctor is to be able to see the other person's viewpoint. It's a bit like walking in their shoes, and what is the patient's interpretation of this? And it's about both parties having a shared understanding of the situation, and that can really help to put the difficult interaction right. Patients may have one interpretation of their illness. They might think they're doing very well with their diabetes, but you as a doctor know that their HbA1c is on the upcrease and they're putting on the weight, and actually it's a very different story. So it's about being able to look at the situation and seeing it from the patient's viewpoint, seeing it from their shoes, and trying to reach a mutually agreeable situation or a shared understanding of the same image. And it's easier said than done, by no means least. So I'm now going to introduce you to there are many models out there, and you might have come across some of them in your training, but there's many models on how to approach a difficult situation or a challenging interaction with a patient. And this is one I really like, because the one thing we'd all like in a challenging situation is to be calm, collected, and take, you know, an even keel approach, and not, I suppose, to get anxious ourselves, and be able to deal with it. And the real key, as you well know, as a professional and as a doctor, is you need to maintain a professional relationship and aim to maintain that doctor-patient relationship if at all possible. So I think the CALM approach is really good. CALM is the acronym, C-A-L-M, and CALM is about composing yourself, adopt a relaxed approach, and sometimes maybe not physically taking a deep breath, but thinking, before I respond here now, do I know how I want to respond? Just take a second or a moment before you give your reaction. Maintain good eye contact, good body language, looking at the patient in the eye, and be prepared to respond positively. Remember, you want a good outcome out of this challenging interaction. Again, attention is really, really key. Give it your undivided attention. Remain focused on the key issues. You've got to sometimes ignore the throwaway comments or the additional comments that really aren't going to improve the situation and that can end up in you getting distracted. So focus on the key points and aiming to de-escalate the situation and achieving, where possible, a positive outcome. Remember, L is for listen attentively, identify emotions, because actually even apologizing to the patient when something goes wrong, or apologizing that they're upset or annoyed, can actually be a very simple way of de-escalating the situation. So being aware of the patient's emotions, and remember to hold your response until they have finished. If you interrupt, they're less likely to listen to what you have to say when it comes to your turn. Moving on is the key. You want to get to the other side of this and hopefully reach a good outcome. If something has gone wrong, and again, I can't stress strong enough about apologizing. Remember, apologizing goes a long, long way to actually de-escalating the situation when something has gone wrong. And quite a lot of clinicians, from my own experience, think, gosh, if I apologize, I'm really only opening a can of worms and they're going to come back at me and take a case against me, or, you know, write a complaint to the medical counsellor, write a, you know, litigious letter or get a solicitor involved. No, it doesn't. If something has gone wrong, all the research shows that actually if you apologize when something goes wrong, early on, actually, the opposite occurs. They're much more likely to de-escalate the situation, much less likely to take a claim or a case against you. And actually, it can be a real game changer to setting the consultation on the right foot. And discuss and agree how you move forward, identifying what has gone wrong and how you can actually put it right. So that's just a model, the CALM approach. It may or may not work. Hopefully, it's aimed at setting the consultation in the right direction. So I just see some more questions up there. I'm going to keep an eye on the chat box. From experience, if at all difficult to resolve the situation, you may ask a colleague to take over and see the patient. That's very true. I've actually that Rita coming up in the next slide. If it's a situation that's escalating out of control, the first thing is to ask yourself, obviously in any challenging situation, is, can I manage this? Do I know how to manage this? Or do I want to manage it? And sometimes you might feel, actually, I can't manage this, and just taking a step back, popping out, getting a colleague, or if you're a trainee, getting maybe your trainer or a senior doctor or a senior person in the practice to come in and support you and maybe take over the care. It's a really, really good point, Rita, because actually, if you think you're not able to manage it, or that it may add fuel to the fire, it's going to escalate in the wrong direction. And actually removing yourself and asking a colleague to take over if you think the relationship is irreversibly broken down, that's a really good point to make. And that brings me on nicely to the next slide, actually, is if you're in a situation where you feel threatened, remember the duty of care when looking after a patient starts with you. You need to look after yourself first, and your personal safety is always of the highest priority. Remember, property is not worth fighting for. I remember personally being in a challenging situation in a practice a number of years ago when I was in our own practice, and sitting at my consultation desk, and the patient sitting in front of me, and he took out a screwdriver out of his bag and he started hammering it on the desk, and he said he wanted the prescription pad in the room. I got an awful fright and I froze to the chair, is all I can remember, and thought, my gut feeling here, do I fight for the prescription pad, or do I hand it all over, or do I just get up and get out of here pretty fast? And I can tell you, I removed myself from the situation, because I thought, if he takes all the prescriptions, my personal safety is more important here. And that's really key, is just read the situation. If you're feeling threatened, remove yourself is the most important situation. Property, and property is not worth fighting for in a challenging situation. Never stay in a situation in which you feel uncomfortable. As Rita said there, seek assistance early. Depending on your practice setting, have you got security involved? It might be about calling a senior colleague or somebody else in the practice to come and support you. And that brings me on to really thinking about what is the situation in your clinic? And you might all want to think of, actually, what do we have if we've got a challenging situation? Is there a policy within the clinic? Who do I call? How do I escalate for help? In one practice I worked a number of years ago, we didn't have a very fancy system, but we just had, you picked up the phone and we had identified a code between us, that the purple folder was what we asked for if we were in trouble. So even just something simple like a universal code, phoning receptionists, they can have the purple folder, they know you're in trouble and can come to your aid. I just see one question in the chat box. What about keeping silent if no response from anybody? Sometimes keeping silent may work, and it might give the patient and yourself time to think, but it's about reading it. If there's no response and you're not getting anywhere, you've got to read, is it worth going on with the consultation? If they're frozen, you might ask them, do they want to see a colleague? Or it's a difficult one to be, really, Samaya. Keeping silent if you don't know what to say, but if the patient is waiting for a response, the silence might also aggravate the situation. Unfortunately, in these scenarios, there's no right, wrong answer, but you've got to just read it. Sometimes staying silent, the patient might take up the opinion that actually you're not going to answer them and you're just ignoring them. So it's about reading the situation. If the patient wants more time to think, sometimes that silence can seem to go on forever and can be really challenging, I would admit. But it's, if you think silence is getting you not anywhere fast, then you might say, I'll just step outside. And you might even just want to go to a colleague next door and say, help me here, how do I answer this situation? Really think about your responses, your tone again. You know, irrelevant comments might escalate a situation and might set things, make a bad situation worse, basically. And I always think if you're in a situation and you think this is getting very threatening, never ask the patient to leave the room, because that actually can make things worse. It's safer for you actually to, you know, to leave this challenging situation just by saying something simple. I need to step outside, or I need to pop and get something, and actually that removes you from the situation. And that brings me on to the next slide, which actually looks at some practical tips to reduce your risk within the clinic. And I'm going to really, these are just some kind of top tips that you can do for maintaining your personal safety in a challenging interaction and in your surgery or your clinic. So first of all, it's, you know, I suppose having a system within the clinic to report a conflict situation. So what have we got in my place of work? If you're thinking about where you are now, if you think about now, if you're in your clinic and behind your desk tomorrow, what do I do if I've a challenging interaction? How do I call for help? What's the system to report the incident? And again, thinking about what's the system to report it, but also how do I document it in the clinical file? Because, you know, you might have some patients who have a challenging interaction with Dr. Fatima, but they don't have it with Dr. Leah, and it's, you know, they might be nice as pie to one clinician, but not to the next, and this might cause challenges within the healthcare setting itself. So you might want to put a marker on a patient's file if there's been a challenging interaction, and it might so other clinicians in the building will know that I suppose that incidents have occurred in the past. Really important, if you've been in a challenging interaction, that you actually take time out for yourself following an incident. We all know those really difficult interactions can make you feel really low, really hurt, frustrated, angry, annoyed. We've gone through all those emotions, and it's very difficult to just leave the difficult interaction out the door and turn around and have to put a smile on your face to see your next patient. So take that time to debrief, some time out, catch a cup of tea, cup of coffee, and gather your thoughts before you go into the next consultation. Thinking about if you're a trainer or if you're a senior staff member at the practice, have you got support for staff? Is there a system that you can debrief and talk to others about it? What's the protocol in your clinic for involving security, or perhaps worst case scenario, escalating it to the local police? Have you a separate area to deal with upset or anxious patients? Sometimes if a patient gets upset and annoyed at the reception desk, and it might be opening onto your waiting room, what you don't want is all the other patients looking in at this incident. So maybe having a separate area that you can take the patient aside and step into a spare room is also very helpful. Thinking about personal safety, have you got security cameras or other measures in the environment, especially if you're leaving late in the evening? You know, you don't want to be going outside your building, poorly lit, and, you know, somebody who you've refused a prescription for addictive medication earlier in the day to be waiting outside for you. So CCTV is important, and well lit outside the building is also really important. Again, thinking about the layout of your clinic, are there consulting rooms which, when they're not in use, are actually locked? So patients wandering around the building haven't access to rooms where there's medication, and when you go around last thing in the evening to lock the premises, that you find a patient sitting inside there before you. I remember a number of years ago here in the city of Cork, where I live, a family physician, or GP as we call them here, went into work on Monday morning and had found a patient had used the drugs and was comatose on the practice floor, having got in the back window, was waiting there for him on Monday morning. So just thinking about your security within the clinic is also important. Again, layout of your individual consulting room. When you're sitting behind your clinic desk in front of your computer, if you have that difficult and challenging patient, where is their seat situated in relation to your desk? Have you got a line of escape to the door, or an easy way out that the patient isn't obscuring your exit? And they're just simple layout measures in the clinical room that you can actually just think of that can make things easier in a challenging and difficult situation. Again, personal safety, you might want to consider panic alarms. I said good external lighting already. You know, the very rare time it does happen, you hear about doctors who've been assaulted on their way home from work. In this country, doing house calls can be a challenge. So, you know, sometimes letting your spouse or your loved one at home, knowing what time you're going to be home from work in the evening, and then if you're running late, they can see where you are, because what you don't want is a difficult interaction or a violent or an aggressive patient, and nobody knows it's happened until the rest of the staff come in tomorrow morning. Again, having, within your policy, when do you contact the police if at all necessary? And then thinking about prescriptions and medications within the surgery. Are they locked away safely and not, within easy access to patients who might be seeking addictive medication? And again, considering a personal attack alarm. We're actually nearly there and we're good on time. It's just 9 o'clock. These are the references that I have mentioned throughout tonight's discussion or workshop. I will send down a set of slides to Vicky and to Isha, so you can free to access them yourselves. The first 3 are the papers. They're really, really interesting first 2 are 2 papers I mentioned. The third reference here, and although it's our Health and Safety Authority here in Ireland, has actually produced a really good pamphlet or leaflet on managing the risk of work-related violence and aggression in healthcare. And although some of the legislation refers to Ireland, there's also some really handy and helpful tips that you might use in your own workplace environment, or that you could adapt if you were developing a policy or a procedure around, challenging interactions and safety of your staff within the clinic. And the final reference I have there is a book that I would say I use on a day-to-day basis. It's the Safety and Improvement in Primary Care Essential Guide. It's written by Professor Paul Bowie and Carol DeWett. They're 2 experts in human factors. And it's chapter 24, and that is where I source the CALM model for challenging interactions. And it's a really good book because it's also got other useful tips on just, I suppose, risk management and patient safety issues in primary care and family medicine, of which I am passionate about patient safety. Because at the end of the day, we want to keep our patients safe, but also us as clinicians is really important, because if the clinician isn't safe, they're not going to be able to look after the patient. So that brings me to my last slide. Thank you all very much for listening, and I'm here to answer any questions, any comments, or should I say, I'll try to answer them.
Thank you so much. It was so nice, to the point, and it's a very important part in which we as a physician in the practice, I think we face it. If it's not daily, it's at least weekly that we have some difficult encounters. If there's any questions back in the chat.
Okay, I'll just wait here. Thank you for all the nice comments. That's really good. Again, I've just put up my email address here. I do some consultancy work. So if there's any, issues, Aisha, that you, after the presentation, or particular topics or area of interest that I may be able to help you with, I'd be delighted to help out.
Yes, sure.
I can't but say that challenging interactions can leave, a sour taste. You're jealous. So what are you jealous of, Alaya? That's very fun.
The pictures of females.
Oh, All the pictures were of female physicians. Oh, I think I had one where I had the family doctor of the male. Next talk, I'll make it work on the men.
Okay, that's good.
What distinguishes a good family doctor is his or her good communication skills. I really think they're very important, Dr. Badger. This is really important. It begins with the actual practice. See more build up on your experience. It does, yeah. You know, it's like everything we learn from experience. And I would also say we also learn from colleagues and how good their communication skills are and how they respond to challenging situations. Because, you know, we learn from each other. We learn a lot from individual interactions, but also how our colleagues interact at work. So it's really good. So apologies I hadn't more men on the photos. I'll certainly make an effort for the next one.
Just a joke. Okay.
And whoever left the comment that they're jealous and they liked Cork, I'll have to open back that invitation. So hope to see you back sometime in the future.
Yeah, we will. Thank you so much. It was so nice, so comprehensive. It covers the most important thing. And I think this is just we need to practice. And as you said, we need to share the experience between each other. And we learned from seeing the patient actually and facing them in the real life. Having a safe practice is very important to have good care for our patients. Okay, if there is no more comments, I would like to thank you both, Susan and Brian, for today and being with us this evening. And we hope that we see you again next webinar or masterclass.
Thank you very much, Dr. Isha. It's a pleasure to join you all this evening. Yeah.
The attendee here, thanks for you all for being with us. I know Ramadan and everybody was fasting today. You will receive a survey link by email and your certificates of attendance. Vicky will distribute it for everyone, so we have feedback. Thanks and good night.
And Dr. Isha, I will send a copy of the presentation. I'll CC Brian and yourself and Vicky into it to share with your colleagues.
Yeah.
Delighted. If anybody wants to contact me, I'll be delighted to help.
So much. So we will have it. We'll send it to everyone with the survey. Thank you so much for this. Okay. So see you all. Bye.
Thank you. Good night from Cork.
Night. Yeah.
Good night.
Bye.